So for those of you who don't know me, my name is Brian Golden. I'm the Vice Dean of MBA programs here at the Rotman School. I'm also the Sandra Rotman Chair in Health Sector Strategy and a Professor of Strategic Management at the Rotman School. Thanks for all joining us on this bright and early morning. For those of you who've come up from south of the border, we know it's a long weekend, so we especially appreciate you joining us today. Before we get started, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississauga of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. I've got the great pleasure of acting as Master of Ceremonies for today's proceedings, and these proceedings would not be possible without Sandy Rotman, the namesake of our Center for Health Sector Strategy. Sandy is here in the audience today, and I would like to take a moment to acknowledge her for her unwavering support of our research in life sciences and health sector strategy. Sandy, thank you for your continued generosity. Since the founding of the Center, and I did a little count yesterday, we have worked with over 5,000 health system leaders and MBA students in healthcare and the life sciences in the last 14 years. And this past year, we launched our global Executive MBA in healthcare and the life sciences. It is truly an amazing program with amazing students. It's a unique program for mid-career working professionals in the public and private sectors from all over the globe. We study in Toronto, the San Francisco Bay Area, and Singapore. It's truly a global program examining health system best practices and what's possible. In the spirit of what's possible, this is our first biannual Sandra Rotman Center for Health Sector Strategy Conference on AI, digital, and the creative destruction of careers in healthcare. We hope you found the title a bit provocative. Our goal today is to examine how artificial intelligence and digital technology are fundamentally changing the way we deliver and engage with healthcare. We hope you leave today with cutting-edge insights that will help you lead transformation in your organization and in your career and in your system. Our plan is to host this conference every 2 years so you can stay at the forefront of what's happening in the healthcare industry. To kick things off, we've got Dr. Alistair Eerskin. Alistair is the Chief Digital Health Officer at Partners Healthcare in the U.S., and he will share with us a 40-minute keynote talk on digital health and transformation of the care delivery team, followed by a fireside chat with me. And that will be the model for the day. We've got wonderful keynote speakers, wonderful moderators coming after me, and we'll end the day with a moderated panel with all of our keynotes. So please join me in welcoming Dr. Eerskin.
Let's see. Okay. So it's my pleasure to be here today. Thank you very much for inviting me. My name is Alistair Eerskin. I am a pediatrician and an internal medicine physician. I function as a hospitalist. And I come to you from Partners Healthcare in Boston, which is the system that is responsible for the Mass General Hospital, the Brigham, and so forth. And what I wanted to share with you today is a little bit about our experience in terms of what's been going on in care transformation across the system. I wanted to just level set a little bit around what we're trying to accomplish. Always a useful thing to do whenever you start talking about things around technology. So if you bear with me for just a couple of minutes and look at this slide, if you see right here on the right-hand side, the level of care. And level of care meaning that as this purple line here shows someone over time having to get different care across our system, they have different care needs depending upon how sick they are. And the way that the healthcare system is organized, and I've dramatically oversimplified it here in terms of home or at the clinic, an ambulatory type of setting, in a skilled nursing facility or at a hospital, it's being delivered in a slightly more jagged fashion than what really people truly need. And what that does as a consequence is it generates a little bit of unwarranted utilization in the care that's being delivered. So imagine a scenario where somebody's in the hospital, in the emergency department, and you would, under normal circumstances, send them home, but instead you end up admitting them to a hospital because there are not enough services, virtual services or other type of services that can support them, so they end up being admitted when not necessary. And similarly, there are a series of unmet care needs that emerge in situations where somebody chooses not to go get care because they have lack of access on other issues. So I think just thinking about how the current brick and mortar structure of healthcare is designed, is there a way that we can bring in a future where there's a better approximation of the services that we offer to patients with the use of technology, by trying to squeeze these two together with electronic health records and artificial intelligence and digital health technologies kind of going forward. So that's the hypothesis that we are going forward. And I just want to say that we've come a long way. This is a system that I trained on, and I still have some heart for it. We used to have this little light pen that you would touch onto the screen, and that's how you would click through things. It was an actual little mouse. And the screens flipped super fast, and it was, very, very quick, except it took like 500 screens to get through what you needed to get done. So it's not to say that we haven't actually made some advances in the past couple of decades. And where I'm from in Boston, it's an ecosystem of life sciences. A lot of money is being spent. Last year, $1.7 billion in venture capital dollars were spent in the healthcare space with a number of different companies that are all trying to sort of nibble away at the problem statements that exist in the healthcare. And then on top of these electronic health records, and I just want to mention that in the U.S., where I'm from, the deployment, the implementation of electronic health records is pretty much ubiquitous. About 96% of hospitals have EHRs, and most physician practices have electronic health records. So the hard work is done, and the really hard work is yet to begin. One of the things that has emerged is a series of different apps that sit on top of electronic health records as a way to be able to address some of those workflows that are not perfectly addressed by the major EHR vendors. This is an example of the kind of list of these apps. Is a tool called smartapps.org. And it's just to say that there's some ability now and some innovation around how do we kind of use this digital health app kind of tools embedded, insinuated into the clinical workflow, which is the way that seems to be more natural for people not to be interrupted by having to go to a number of different places. And as useful as this may be, there's no real business model that surrounds how you actually transact. This is not like an app on a smartphone that you download, you don't like, and you just delete. There's all kinds of other transactions that have to occur in terms of indemnification and various different laws for privacy and other things. So this is an emerging field, but it's one that's it's not gotten us there yet. This is an example of what an app would look like in a Cerner system. It could be any system, Epic and any others. And it's basically one that is designed for rheumatologists. And the electronic health record company themselves wouldn't go through the trouble of pulling this type of subspecialization into view. But to a rheumatologist and a patient that's suffering from joint pain, it becomes incredibly helpful to understand what's the pain in the joint, as reported by the patient. How does it compare over time to the treatment that's being provided, whether it be biologic and others? So the idea is that some component of this screen is the electronic health record, and the other component of the screen is the app. But to the user, they can't tell the difference. They're just kind of in their system, in their workflow. They can't tell the difference between the two. But despite all this investment in digital health, the billions of dollars that are going into it, the apps, the kind of ingenuity that's going into electronic health records, I think we're a couple of days away from this surgeon who's walking through what could potentially be a future in terms of usability and be able to understand how to use these systems. One of my own colleagues at the Brigham, one of the surgeons, well known, Atul Gawande, who's written several different books, somewhat recently, wrote an article about why doctors hate their computers. And if you read through this article, there's a number of different kind of workflow-related issues that are problematic in and after the implementation of electronic health records. And he does, as he usually does, a very eloquent job of articulating what some of those problems are. And some of them come down to the fact that you have fragmented workflows that have been adapted digitally. Some of them are just associated with the fact that the computer feels like it's in the way between the patient and the provider relationship. And Atul wasn't the only person to complain about the fact that there's opportunities for improvement. Another more recent article came out called Better Research, called Death by 1,000 Clicks. And I round every Friday across the entire system at Partners, speaking with physicians and nurses and pharmacists and everybody else that's part of the healthcare team. And I'll sit in the waiting room and talk to patients on a regular basis, trying to understand better what is working and not working for them. And the one thing I do hear from the clinician side is too many clicks. So this kind of resonated very well. And this article goes through a series of different topics, which I won't go into in broad detail here, but basically kind of outlining some of the problems that exist with these electronic health records. And I just want to kind of frame a way of looking at this and make the case that the electronic health records is a bit at the tip of the spear. There's a number of things that surround the electronic health record that are contributors. Whether it's the fact that the data that's being mined from it is to be used for AI, it's a data-hungry thing. The fact that researchers need to get more information than what may necessarily be useful for actual clinical care. In the U.S., we enjoy an enormous administrative burden, especially from the billing side of the equation, that gets embedded into the electronic health record and requires many more clicks than is necessary. And several years ago, when I would hop on a plane, I would just, I would be able to get to the gate about 10 or 15 minutes before my flight left, and I could just make it and get onto that flight. These days, I can't do that anymore. Why? Because I'm going through security. I'm kind of partially undressing myself as I go through the various different things. I have to take all my electronics out of my pocket and so forth. And so that experience, compared to how it was before, is certainly not the same. And the same is true for the electronic health record. The experience of being able to access, have passwords that are expiring, have different ways that you have to kind of re-authenticate and so forth, cause the ability to just kind of go into the system, get what you need, and get out more complicated and more difficult. One would assume that in a system that now has mostly digitalized healthcare, as in the U.S., that the interoperability between those systems would be solved. And in fact, that's not the case. And it comes in all kinds of different ways and forms, and we'll kind of get into it in a little bit. But I'm just trying to make the case that there's a number of barriers to usability that plague EHRs in and of themselves that cause things like burnout. If you can read this slide, then you should get an award. It's not meant to be read other than to show the fact that this is what's called meaningful use. And this is a program in the States that spent $36 billion in trying to incent the U.S. to adopt electronic health records. It was successful to the extent that people adopted electronic health records. It was not successful in reducing the overall burden of being able to report and remove administrative burdens. The point about this slide is there were a lot of things that were embedded then as a result in terms of people having to prove the fact they were using the system meaningfully to a government system. If you've heard of ICD-10, it was a Y2K for us, earlier on in this particular decade. It's gotten to the point now where people are illustrating the various different ICD-10 codes that exist, as you see here: unspecified balloon accident injury, occupant, sequelae. This whole book illustrates some of the sort of ridiculous types of diagnoses that emerge from this kind of coding system. And it's not to be disparaging about it. It's just the fact that we've sometimes complicated the way that we call something like pneumonia or heart failure, or things that are interpretable by mere humans. And then from a health information exchange standpoint, despite the fact, again, that we've digitalized, the health information exchange is not a new concept. It's been going on for many, many years. It turns out that in the 1990s, it was called the Community Health Information Network. Then the name changed to the Regional Health Information Organizations. Then the name changed to the Health Information Exchange. And I think we suddenly realized if we just keep changing the name, we may not actually solve the problem. And so I think that's an ongoing issue, and I think trying to kind of come up with the Rosetta Stone instead of the Tower of Babel has been a much more useful pursuit in terms of what we're trying to accomplish. Compared to our Canadian friends, we find that we put a lot more characters in our notes than you do. We can learn from you. This is just a graph that shows the number of characters in the note in an ambulatory practice. And as you can see, the entire world is the dark green, and the U.S. is the sort of light green bars. And we must be writing something pretty compelling, or we must be writing a lot. And this is a manifestation in part by the fact that we can, the term is blow in information into the note about labs and medications and so forth that don't necessarily add meaningful narrative to the note, but meet a lot of different billing requirements. In addition to these problems that exist, there are some sort of vexing technologies that just won't seem to die in the healthcare system. And some of them are listed here. For some reason, the fax machine now is re-emerging as a safe communication strategy, because who else is going to intercept a fax other than another fax machine? We have pagers, and some of us use pagers and continue to use pagers, and Motorola is saying, please stop buying pagers. We can't find parts for them anymore. And of course, these are the same clinicians that are using smartphones and have them in their pocket and have these two different things. We do most of our transactions on a telephone. People call to book an appointment. I go to a restaurant, I book my appointment on Open Table. We have online ways to book appointments. People are still using the telephone. And there's this curious little device called a CD-ROM, which is what you get when you go to hospital information management system to get your medical record. I don't know that you can buy a computer anymore that has a CD-ROM. So we're giving people a thing that they can't actually use to actually look at their records. So there's probably some but these are technologies that have all been usurped in terms of, from a technological standpoint, certainly not usurped from a kind of cultural adaptation standpoint. So there's some barriers to overcome. And then we're not the only ones that are trying to solve the healthcare problem. CVS, a pharmacy, a common pharmacy, are developing hubs throughout the United States. These hubs have a dramatic investment in digital health and what they call digital front door. So this is ways for people to be able to introduce ways to gain access to a school physical. If you call my system and call a pediatrician like myself, and have to wait several months before you have an appointment, then a mom is going to say, but I need my kid to go to school next week, and our system is restarting. So I'll go off the fly. So this was probably a an upgrade. How convenient. So anyway, I think that the basic point is, and CVS is not the only system actually out there. There's a whole series of different vertical integration that is currently existing that are kind of bringing these different hospital systems together. And in fact, it's not just CVS, it's other big tech companies that are kind of involved. And I see a lot of Microsoft in the room, but as you can imagine, there are a number of other big tech companies that are each doing their own to be able to invest into the healthcare space and nibbling at the edges of the margins of where, especially consumerism or advanced diagnostics or decision support aids exist to be able to help out. So that's kind of the problem statement and some of the places where we are in terms of their competitive threats to the way healthcare is being designed today. And we're in a position where we have the opportunity, and in fact Canada has the opportunity to learn from some of these lessons and avoid them. So that's the hope and the desire. So when it comes to the next topic, which would be about the application of artificial intelligence in healthcare, I think it's safe to say that there are some practical applications. You'll notice that you'll see algorithms right now that are being put into papers and research articles that show, for example, that a dermatologist is equal to a computer in terms of being able to interpret certain kinds of moles for melanoma. You'll see that images of the back of the retina is processed by AI and can as easily identify retinopathy in patients that have diabetes, and in fact do so in a way that is independent of gender and ethnicity and other ways that sometimes can hide a condition or a disease. And you will also see that there are algorithms that show that you can diagnose and interpret a mammogram better than pathologists that are looking at these things. So it's just important to be aware of the fact that there are a series of different tools that exist out there that are augmenting today what the clinician can do. They're not replacing what the clinician can do, but they're certainly augmenting that. In my experience, in terms of things that actually work and things that have actually saved lives, if you take information that comes from a diagnostic imaging report and you're able to extract some of that data from it, you can actually automate some of the ways to go find patients that fall through the cracks in terms of what's going on with somebody who comes in with a trauma, who gets a pan scan of the CAT scan. They find some other incident or findings that need to be followed up, but then they don't get followed up. And these are patients that could sometimes have very serious conditions like an abdominal aortic aneurysm. So we built a whole series of different things that would identify lost to follow-up patients with certain key conditions. We would contact them. In some cases, they had gotten their condition solved elsewhere, and in some cases, they were still running around with basically a time bomb in their belly. We'd invite those patients back into the hospital, perform the procedure, and these are all patients who would have succumbed to that illness if we hadn't gotten to them. So there are some ways that the approach of taking AI and natural language processing and so forth can actually help. And in fact save lives. And that's an important component. I'll give you another example, very practical, of a lady who comes into your office who's 86 years old, who feels a little bit dizzy, and you're not quite sure what's going on, so you go ahead and get a CAT scan. And it's on a Thursday, and you just want to make sure this, everything is looking okay. That film is an ambulatory film and sort of gets read in the prioritization of an ambulatory film. Sometime on Friday afternoon, the film shows the patient has a stroke, or even closer to that, the patient has a stroke immediately after they've been examined. Well, in the way that it normally kind of first in and first out, that film may not be actually read until it just gets read based on all the work that's been done. So what we've done is we've gone through the process where AI actually looks at those CT scans instantly as soon as they come out of the scanner. And when AI establishes the fact that actually there's a potential 96% likelihood that this patient has a stroke, that film just gets put at the very top of the reading list. So it just reorganizes the stack. And to the radiologists in their workflow, it's nothing different than them just grabbing the next film that's there. But to the patient, it becomes incredibly important to go from a 4-day down to several-minute recognition of that so that we can do something about it. They're just a couple of examples of how that works. I think that there are other dimensions of, as I continue ad-libbing and riffing, there are other dimensions that exist in terms of things to consider relative to AI, and I would say that goes into the what's interpretable versus what's not interpretable. And what I mean by that is if you come up with a really clever AI solution, and I've gone through this. So one of the things that I've really benefited from in some of my training is I had to do my own AI. So I took 800,000 lines of patient information and 10,000 different features for those patients, and I ran my own AI and sort of the various programming things. And you suddenly becomes very, very clear what some of the limitations of AI exist. In terms of how the data needs to be managed and curated and cleaned up, and then how that data, even when you get an answer, needs to be implemented and adopted. So when you end up with something that you run against that AI, and by the way, the AI part is like 5% of it. It's a very small component of the overall work. It's very, when you run it, it's like it takes a few minutes, and you're like, that was it? That was the AI part of it? And the harder part was all the management part and all the implementation part. But if it's not interpretable, and you're saying this AI is going to make a decision as to whether the patient goes to the OR or whether they stay on the wards, it's a hard thing to sell, to say, well, okay, well, if there's a mistake or if there's a bad outcome and you go back and look at what happened, well, why did that AI tool say that? I don't know. It's a big black box. It's an Ising sphere that has dimensionalized 10,000 different dimensions, and that's why it came out and it just popped out that answer. It's harder to make the case that that was something that was reliable compared to something that's interpretable AI. And the way interpretable AI works is that it looks at the data and it classifies it in a way for you, and then it develops an algorithm. And you can follow that algorithm and say, all right, here are the branch points, and this is how I get to this particular component. And that becomes very helpful. So I think there are applications for non-interpretable AI at this point of saying, how do I organize the work? Non-interpretable AI may be what I was describing in terms of being able to detect stroke in in a pending CT scan. It's okay if it doesn't get perfectly listed as the next scan to pull. But it's useful to make a distinction between the different ways that AI works and then how they get applied. I think the other thing that's necessary in order for us to consider being in a position to be ready to adopt AI is the various different data systems that underpin our transactional systems. And so what I mean by that is there's some information that's inside our electronic health records that doesn't fit very nicely in rows and columns on a database. And those could be clinical notes. Imagine all the time that we spent writing information about how to interpret what's going on from all this objective data. Those clinical notes need a different form of computer infrastructure. And you've heard about big data or Hadoop or the way to be able to support that. Various different Apache tools that sit on top of that are all open source that help you be able to tease out some of the useful components of that data and then make them digestible and make them available to the various different tools in the form of these APIs or programming interfaces that can work with them. I also wanted to mention that the new currency these days is the data. So a patient walks into the hospital, various different components of examinations are being performed, and that outcome, that secondary use of that data becomes incredibly useful to biotech. It becomes incredibly useful to pharma researchers and a number of other people. And that currency, the same kind of importance of the currency of data when it comes to when it comes to all the other industries that are using that data to sell us things and so forth, is becoming just as important when it comes to AI. Thank you.
It is ironic that we're going to paper.
It is. It's always important to have a good backup mechanisms. Excellent. Thank you very much. Let's see where we are. I'm going to go ahead and hold on to the paper just in case. All right. If there's a way to make sure the little clicker, there we go. All right. That's right. Let's see. I'm just advancing back to where we were. Let's see how close I was to whatever it was that I was about to say. All right. This slide is more helpful in terms of just trying to describe some of the practical applications of AI. We use a lot of robotic process automation. So what that means is remedial steps. There's a lot of people that actually are constantly doing work that is sometimes mind-numbing work, and that they could do work that's more value added. And in fact, the computer can take over. And what's nice about, and we actually name these in our HR system with names like Eva and Frank and so forth. And the nice thing about Eva and Frank is that they don't take any vacation ever. They don't have any, they don't need to have a salary increase. They just work constantly. And so that ends up being very useful. You can imagine the application of AI in terms of identifying patients that are being centrally monitored. So we have a central monitoring system and ways to be able to identify patients that are, before they end up decompensating, that the system picks up some key cues in either the raw data or some of the other data to be able to capture that patient, send a rapid response team before they get worse. The access in the U.S., and I'm sure everywhere around the world, if you just read any of the comparative health scenarios of how healthcare is delivered, access is a major issue and a major problem. But in fact, chatbots can provide some initial way to be able to screen patients and then provide some triage functions in a very automated way to get the right patient in the right place, and that can be very, very helpful. I was discussing the issue around algorithms that help with identifying patients to avoid codes outside of the ICU, decision support systems that help identify key patients. This is 17% of these patients. I don't have the actual article here. Were better identified for the first chemotherapy agent that would be less toxic because of the way AI was able to understand this. And then a series of different throughput and prioritizations benefits in terms of AI. This was the slide to talk about interpretive versus non-interpretive and the four basic views on how you can look at an algorithm cheat sheet of how you go supervised and unsupervised ways of applying AI in terms of black box versus interpretive. This slide was really more to discuss the fact that it's not just blood pressure that we're getting. It's blood pressure and all the other ways that we get blood pressure, whether it's from a smartwatch or whether it's from some wearable device or a telemonitor and a physiologic monitor, it just, the way the data is being compounded is just exponential in terms of how complicated it gets. And so we need systems that can accommodate streaming data, as well as data that's actually discrete and available through a different tool. And that requires a combination of big data systems and traditional relational systems to be able to do all the things that we're looking for. So I'm sorry, I'm going through these a little bit fast just so we can catch up. This was the real use case of the patient with the abdominal aortic aneurysm that I was talking about that we were able to identify. And here's the real use case of the image classification of patients with stroke that we were able to get to much sooner as we were reorganizing the PACS workflow list for those different patients. And I'm happy to share these slides with anybody who would like them after the talk. Here was a comparison, an algorithm that outperforms pathologists in the detection of breast cancer. Here's how it does with dermatologists, again, as good as dermatologists in diagnosing. And then here's the retinopathy examples in terms of ophthalmologists and the ability to look in the back of the eye. So let's talk a little bit about headwinds that exist relative to AI. You know, any new technology, blockchain would have been no different than AI, and it would be no different than quantum computing in the future. You know, what something ends up being like the thing that everybody looks at in technology, and it's accompanied initially with a lot of hype. And hype isn't a bad thing. It accelerates the interest of people, but sometimes hype tends to overpromise. Today, if I just take a cereal box and put AI on it, we're going to sell more cereal. So anything that has sort of an AI stamp to it is going to end up, you know, being something that sells. But that, you know, I think that we're getting to the point where it's sort of peaking out on the hype of AI, and I think it's going into, Gartner refers to this as the trough of disillusionment, which sounds very depressing, but it's just this area where, you know, the reality and the hype sort of catch up with each other, and then eventually it plateaus. AI needs to be also validated. As you all know, the way that you kind of go through the AI process is you have a data set, you take a portion of that data set, and you build your algorithm, then you take the other portion of the data set and you test it against what you built to make sure that it's internally valid and it's able to internally predict what you're looking for. The issue becomes when you sort of uproot that and move it to maybe a different location or a different ecosystem, a different part of Canada from where it was designed. And some of that inherent bias and some of the unconscious bias that goes into that data has to be taken into account as you move it, and in fact sometimes has to be retested every time you move it and retested until it stabilizes and gives you the same result where you have a broad enough population that's been able to help it. I think education is another key part in terms of how do I apply and when is the right time to apply. We need people within the healthcare team, just like an ID doctor comes in and says, I want to give this antibiotic, so you should give that antibiotic for this particular condition. In some ways, you need sort of AIists that are on the team that are saying, this is the right application of this AI tool versus that application of the AI tool. And then, you know, there's a number of other things I think that other speakers are going to go into in a lot more detail around leadership and incentive, consent. Is consent implied? Can I use the data that I collected as a byproduct of care? Is it okay for me to use that data? I think the Europeans are really struggling with this with the GDPR sets of laws that are out there. And then many examples of AI being able to re-identify a patient that was previously anonymized that caused some gastric juices to flow in people who are worried about this stuff. This was just, there's a bar next to Boston that the way you pay for your coffee is with your data. They don't accept cash. So we're talking about the fact that you use this as a new currency. This is directly a new currency where a up-and-coming student you know, says, I'm willing to let you have, you know, by the way, I put everything on Snapchat and Instagram anyway, so what difference does it make? If I can get a free cup of coffee, you can have my data, I'll answer some questions, whatever, and then that's how they pay for the various things that are in this particular cafe in Providence, Rhode Island. I thought that was an interesting, you know, a way of looking at things. So I wanted to also just briefly talk about, okay, so if you have this idea of AI and digital health, and then what are the ways that, again, we would practically do kind of a playbook or apply that in a real clinical setting? And I wanted to share with you a little bit what we're doing at Partners relative to enterprise data and digital health. And the things that we're after are not the things that are that uncommon across anybody who's trying to manage a healthcare delivery system: improve access to care, participatory medicine, providing a number of different home options so the person doesn't have to come into the home, having better decisions like some of the things that we just described, being able to anticipate what's the next best thing to do for a patient depending upon healthcare data, but importantly, depend upon non-healthcare data. We had a series of meetings recently called the Creepy Committee meetings. And they were called creepy because we were trying to think about non-healthcare data that's used for things like data brokers. Can those things help us with social determinants of health? Can those things help us identify patients that are at risk and, in our vulnerable population? And how do we weigh that against the fact that people say, well, wait, how do you know that about me? I didn't give you permission for that, and try to figure that out. And I think that's kind of a treacherous road. And so for the time being, we're just going to examine and not actually do anything in that regard. Also, we want to make sure that we can easily share images. So obviously, going through the process of being able to do remote interpretation and when I think of images, I also think about pathology slides. So being able to scan the pathology slides in 3 dimensions in a remote hospital and be able to bring that information and be interpreted by a pathologist at a medical center becomes a useful way to democratize that capability over people who otherwise wouldn't have it. So we had a call to action ourselves at the partner system, and the premise here is that we say, all right, we need to refresh our facilities, and we have some brick and mortar, and we need to have ambulatory care centers so we can bring care closer to the patient, but we need to have that, in that investment, a digital investment that makes sure we take in full advantage of kind of a synergistic relationship that the bricks have with basically digital bricks. So you can imagine a future tower. This is a picture of the Mass General in terms of what it's going to look like in a few years. And these digital bricks are designed to be able to make sure we enhance the patient experience and improve the operations and do some things around care transformation and digital innovation. And the care transformation example is if you have a cardiologist that can see patients, and that cardiologist sees the patients every 3 months, you can only see as many patients as that cardiologist can handle in that clinic. A care transformation thing that we're doing now that we've had extremely good results with, that's been written up in the literature, is a scenario where that cardiologist works with 3 pharmacists in a clinical collaborative agreement, and those 3 pharmacists work with dozens of care navigators. And with the care navigators are college-educated students who are touching base with the patient on a daily or weekly basis, and they're functioning off an algorithm that was designed using guidelines in AI, and they understand the branch-in logic, and they're basically following, what's the next step. And when they identify the fact that there's a next step that needs to go forward, they contact the pharmacist to get permission to be able to increase the medication, what it may be. What happens is that patient now still goes to see the cardiologist every 3 months, but when they come back for their visit 3 months later, they're at goal. They feel like they've been reached out to multiple times. They've had a chance to be able to report any kind of side effects, differentiate between side effects, for example, on a statin that are serious versus side effects that you just have to push through to get to your lipid goal. So it's a different healthcare team. It's a different way to be able to scale someone with a lot of clinical knowledge out to a much broader catchment of patients. So that's the kind of things that I'm talking about. I'm going to skip this slide, which is just illustrative of what I just talked about, of the difference between, the normal case of somebody has I guess I'm not going to skip this slide. In the case of somebody who smokes cigarettes and has obstructive lung disease, who would normally go see their primary care doctor and then would get an inhaler. And under normal circumstances, everything goes well. That's what you would expect. Except what happens is they really start maybe with a Google search, or they go to a quick minute clinic, and then even after they have symptoms, they're maybe in denial, or they can't get clinic access. And even after they go see their PCP, maybe they don't actually take the medication, or it's too expensive for them. So what is the underpinning infrastructure of digital health technologies that can help support this patient as they're navigating through to avoid the situation where they keep falling off the track? How do we do predictive mechanisms to be able to identify the population at risk? How do we create a digital front door so that those people have an inviting way to be able to come in and find an easy way to be able to find their way to the clinic? How do we make secondary use of the data that is there to be able to make sure that we can better engage them and provide these navigators like I was talking about before? So that's the key point. All right. I'm going to wrap up in the next 3 minutes. Maybe I'll take a few more minutes just for some technical issues. So This is just, this last section is to talk about, let's not put the cart before the horse. All this AI stuff is really fabulous and is important to work on, but there's some sort of basics that can be done in the meantime. One of the things is in a large organization, there tends to be lots of silos of excellence. And a useful thing, as I'm a chief imitation officer. So what that means is I just go and find something that works really well someplace and I use it at another place. It could be something that works really well at some other industry and then use it in healthcare, or something really works well in one hospital and use it in another hospital. So these are all examples of technologies, teleneurology, wayfinding, the things, e-consults is where a primary care doctor sends a note out to a specialist, and the specialist returns that note either within a couple hours or within the next day, so that avoids the patient having to go see the specialist for something that's easy to be able to address that doesn't require an extra visit. So these are just horizontally scaling across the system, makes sense to do. The other basic thing is, like we were talking about in terms of logging into systems, we use our badges to tap instead of using a password. Hundreds of thousands of times a day, people were entering passwords in terms to get into the system. That was keeping people out of the system, and it was frustrating people, especially when you ordered a medication, you had to put your password in again, and just being able to make that process easier. And in my round-in, I would examine doctors who would walk into the room and try to establish that bond with a patient, and the whole 5 minutes they would begin in, they were constantly distracted trying to get the system, put in a password, wait for it to boot up, put in another password again, and wait for it to boot up, and interrupting that patient-doctor relationship, as opposed to being able to walk in the room and not even, break eye contact with a patient and just tap the badge and let the system sort of boot up on itself and be ready when it was appropriate. My primary care doctor uses something called Scribble, which is a virtual scribe. So this is a scenario where they ask my permission, they hit a record button on an iPad, and then I don't think about it anymore. We have a nice casual conversation about what's going on. So far, everything's okay. And then they do a physical exam. They call out a couple of findings, and the only time they touch the computer is to put in a couple of quick orders. And the next day in the in-basket, that doctor receives their entire note organized in the way that you would want a note to be organized, because maybe the information shared doesn't necessarily come out the way that the note ought to be organized. And in this case, it's several doctors in India who are listening to that transcription that was recorded and turn it into a note and put it into the doctor's in-basket for review, correction, and then signature. And it's a way to basically remove that keyboard out of the way between the patient and the doctor. That, over time, will be replaced by purely AI type of function, where now the tool is actually going to get sophisticated enough to be able to do that. But we wanted to get ahead of at least getting the keyboard away, even if there was a human intervention, to ultimately be replaced and be ready for us. There's a number of other things that help out in terms of basic, the traditional sitting in a classroom learning about a system is difficult compared to the instant, at the elbow virtually. So this is, I'm in the computer, I can't figure out how to order penicillin. I call a phone number, within 15 seconds, somebody's in my system with a little icon showing me how to actually do it in real time. Very, very great and useful way to be able to do training, as opposed to I'm in a classroom for 4 hours, I'm falling asleep, and I'm trying to drink coffee to stay awake and remember everything. This article came out in New England Journal of Medicine recently. It says get rid of stupid stuff. If you read the article, the kind of thing it's talking about is clinicians were having to answer a question as to whether or not a 16, 17, 18-year-old teenager still had an umbilicus and if it had fallen off. And you wonder, why would that be the case? I'm a pediatrician, but I know that day 1 or 2, that's falls off. Why are we asking 16-year-olds whether they still? And it was because when the system was built, they just sort of built it and then, kind of put it in, trying to address the 1 or 2-day-old baby, and somehow it got applied to, the entire pediatric population. And for years, people kept saying, no, it fell off. And so, and they got frustrated, and so they would have an enhancement request to say, can you please take that out? It's really not appropriate. And the enhancement request wouldn't sort of survive the kind of Darwinian process of being able to bubble to the top to actually get done. So they kept answering no every single time. So part of the thing is to say, kind of get rid of that kind of stuff because it's annoying, and you have to find a way to be able to manage that. This is just some decision support. And I can only show you limited. This is Epic, and Epic gets really twitchy when you show screenshots. So just imagine it's any EHR system. And the trick here is to make sure that the action you're asking somebody to do is actually embedded within the alert that you're popping up. So if you ask them to do something, make sure that the actual things that you're supposed to do are in the alert, just to make it easier. We did add a little feedback button into this alert, and that generated a lot of very interesting data. So this is an example of an alert that pops up saying your patient is not on a beta blocker. Beta blocker is used for heart disease. And in fact, from another hospital, it was clear the patient was on a beta blocker that was in the system. So the person was saying the patient's already taken a beta blocker. Others had a slightly different set of feedback, complaining about the system. Others were, when we got this feedback, used a lot of exclamation points. I think somehow that was really well emphasized. And a number of other comments that came back about Epic so these are all examples of things. And so what we've done actually is, interestingly enough, we use AI to interpret these. So we stem these comments. We measure the number of exclamation points there are in a comment. And we use an analysis to be able to look at where this comes from and what the sentiment is to be able to react. And actually we have a way every single day of identifying every decision support alert that pops up, and if its behavior is different, if the comments suddenly that are coming in are different. So we actually encourage people, put as many exclamation points as you want in it. We will actually do something about it. In terms of patient experience, I think the key thing is quality and cost was a key value driver before. Experience has been added, and I'm just making the case that add-in digital innovation is an important component of that. People want access to care. They want it online. They want to know what the cost of the care is before they engage in it. They like to have it to be personalized. Of course, they want a care and team around them. The care and team can be just like an example of the cardiologist. The patient feels very cared for, even if the cardiologist is not reaching out to the patient, so long as somebody is, even if it's the care navigator. They expect ultra-modern technology and all this digital information to be shared amongst other hospitals, and they want to be guided that the hospital is an incredibly intimidating place. When you're not used to going through it, it becomes less intimidating when you're used to it. And I think patients have enough to deal with their illness, so they don't need the burden of having to figure out how to get there and who to go reach out to, and there are ways we can help with that. Last few slides. New models of care in terms of virtual, a number of different clinics that kind of put in everything online. You click it, walk, call in, just make an omni-channel view of being able to access care services. A new technology in terms of consumer relationship management, transactional systems that are missing in our midst. So imagine if you pick up the phone and this is the kind of thing that pops up immediately after you pick up the phone to find out that the patient likes to be called Jenny. She's scared of hospitals. Don't book her on a Tuesday because she never shows up on a Tuesday, so offer her appointments on another day, Tuesday. And then at the bottom shows what the experience has been over the past few years in terms of how is she experienced in the healthcare system. Is there anything we can do for her? Similar kind of thing pops up within the electronic health record in terms of for clinicians, in terms of useful information for clinicians. The point is there may be a transactional system that other industries have used very well to provide a better experience that we haven't fully adopted in the healthcare system. At Geisinger, the system that I was at before is in central Pennsylvania. It's an integrated delivery network that has both kind of the health plan and the clinical enterprise together. They are now offering whole exome genetic testing to its members. And the reason is finding 3.5% of the patients that get whole exome sequenced have these high penetrance illnesses that nobody knows about until you actually get them sequenced. So you have 20-year-olds that would otherwise drop dead from a heart attack, from hypertrophic cardiomyopathy, that you can detect and put a defibrillator in them and avoid all that. You can find patients that are at risk for colon cancer because they have Lynch syndrome from a genetic test that need to get screened at the age of 35 and not 50, and changes the sort of the way that you approach that. And of course, patients with BRCA mutations when it comes to breast cancer, be able to get to those patients before and make some decisions about what to do. This is my last slide, and I just want to talk about another innovative program called Fresh Food Pharmacy. And what this did is it took a clinic, split it in half, and put a grocery store in half of it, and kept the clinicians in the other half. And the food on the shelves was actually supplied by a food bank, and it was, and whatever food was necessary that wasn't there was paid for by the health plan. And these were patients that would refer to this clinic that were diabetic and were just not reaching their goals. The medications that we were giving them, the insulin we were giving them, kept something called hemoglobin A1C, which is a measure of how well they're doing with the hemoglobins, was just too high. So what we found is if we gave food to the patient literally, instead of the medication, we just literally said, come in for a week at a time, and we'll give you 5 days' worth of food for you and your family at no cost to you. The patients did dramatically better within 6 months. The hospitalizations were less, the emergency department visits were less, the numbers, the hemoglobin A1C number, where you want it to be less than 6.5, went from 12 to 8% in 6 months. And importantly, the financial impact as well, in order to be able to sustain this, the total medical expense on these patients dramatically dropped as well. So I leave a link for you down here. Apple came to us because they were quite interested in this story, and we were using some Apple tools to be able to support this. In terms of how they could be, when you think about expanding the health system, rarely do people think about, well, we should be buying some grocery stores, despite the fact that that's where where illness begins. So at least we're doing some partnerships now with non-traditional organizations that help us compete against what we're all competing against, which is disease itself. So with that, thank you very much. I appreciate your time.
Thank you, Alistair. And I'm tempted to ask the first question about our dependence on electronic systems, but we really appreciate your resilience, and apologies for that. We're going to have time for questions from the audience, and we'll have microphones coming around as we go. But I want to start off with a few, maybe a couple of questions, and then we'll see how folks want to get in. Partners has to be a business. It's a business with a different kind of bottom line than we think about other businesses. But we are talking about massive technological change and, truthfully, massive dollars associated with those. How have you and your leadership at Partners, had a discussion about the ROI? And what do you think about as the ROI for these kinds of systems? Do you do this because it's the right thing to do for patients or the right thing to do for research? Or is there a business element to that as well, in addition?
Yeah, no, it's a good question, and ROI does come up quite frequently, especially so Partners is investing $580 million over the next 5 years in data and digital health. A pretty sizable investment. So how did we come up with that number, and how did we come up with to be able to support that through the various different finance committees of the board and so forth? And I think that it's several different categories. There's some basic clinical operational things that just with the hurly-burly of healthcare and the way things are designed in various different systems that are certainly not optimized. So you can make a case around point-of-care service collection or reduction in denials or those kinds of things that are kind of fundamental in terms of how the dollars flow into a system. The next level is if you can improve the efficiency of your clinicians by decanting some of their work into digital means, making access more effective by doing some of that work, and then allowing new patients to be come into the system that in a way generate revenue, but more importantly are actually now gaining access to care, and existing patients to be able to be managed in a way that's more intelligent than requiring them to come to the clinic or requiring them to come into the hospital or avoiding that kind of hospitalization. I think in the States, the ROI calculation is complicated by the fact that there are a number of different payment models, and the U.S. is going through a major shift from what's called a fee-for-service model, where you pay for what you do, to a value-based purchasing model where you actually get paid for your outcomes. So as we transition, one of the cases that's made in terms of population health tools and in terms of care management tools, it requires a major digital infrastructure to be able to support it. The last thing I'll say is, there are examples outside of healthcare of people that are worried and obsessed about their customers. The classic examples are Amazon and Apple and a number of others, and they've done pretty well. So they tend to be trillion-dollar companies, and I think that you can make the case that there's a cognitive dissonance between taking care of your customer and the kind of ROI you would get from being able to attract them to your particular organization.
Thank you. Feeds into my next question, and then if those in the audience could show your hands, we'll get a microphone to you as we go along. One of the areas that I'm particularly interested in, and I know so many in the room are the challenges of change management process. And my assumption is not every one of your physicians and clinicians is 25 years old and has grown up with a smartphone in their hand. How have your clinicians, at various generational stages, responded to, either with excitement or reservations or fear or just digging in their hands, to these introductions to new technologies? Across the world, we've seen substantial resistance, not just complaining about the clicks, but whether it will affect their income, whether it will affect their autonomy. So can you talk a little bit about your clinicians' responses?
So it depends who you ask. And this is one of the things that I find so helpful about round in my organization every Friday, is if you go to the actual clinicians themselves, a lot of them will say it's fine. I mean, the systems, actually, I like this. I went to this other hospital. This one's better than the one that I had before. That kind of, the response isn't as negative as you would otherwise interpret from the people that oversee those clinicians. And what happens is the people who oversee the clinicians are hearing all the negative information, not necessarily hearing all the positive information. So there's that just perception piece, which is important. There's also objective data that these systems generate to kind of let you know how individual clinicians are doing within the system. And that objective data actually ends up being very helpful. So I either go find people who are struggling with the system and need some support, or find champions that are just whiz-bang digital natives that actually have ways that they can teach their colleagues how to use the system. I think with the introduction of technology, and this has been written about now for just over a decade, of unintended consequences of technologies in healthcare, there is a shift in you introduce a new system, work shifts around. So the classic example is the intern that is new to prescribe and goes up to the nurse and says, I need you to give this medication. In the non-digital system, the nurse says, you may want to go ahead and check with your attendant. It looks like you're not entirely sure about that. Whereas in the digital system, the order gets placed and you don't get that sort of additional metadata about how sure somebody is about that order or not. And you have these unintended consequences that occur. And I think that, there is fear that AI will replace a radiologist. If I have a tool that can sit there and interpret a CT scan or a chest X-ray, and I don't need a radiologist to do that anymore, then why do I need a radiologist? Can I just start getting rid of radiologists? Well, that hasn't occurred yet, and for a couple of reasons. The good news for radiologists right now is the fact that they are, they are overtaxed in terms of the number of films they have to see and for the turnaround time. The other good news for the radiologists is they're the kinds of people who are very early in this technology with PACS systems and so forth, and somebody needs to be able to help interpret AI. So there's an opportunity for not the job to be eliminated, but the job to be changed for one that actually takes advantage of the new technology. You still need the same kind of critical processing skills and leadership that's necessary to be able to interpret things. But as these new technologies come about, they actually engineer not only the destruction of the current roles and responsibilities, but the creation of new roles and responsibilities. So I think it's that dynamic shift that is occurring that I think is having an impact in terms of how the roles not are being eliminated, but are changing.
So let's bring the microphones up. I've got a string of questions, but I also have the good fortune of being a moderator related
So
today.
please just put your hands up. Me and my colleagues are going to come around. Keep them up so just we can line up some questions. There's a couple of quick house rules. So let's know who you are, which organization you're from, and just keep it to one question because we're going to try to fit in as many as possible. Thank you. We'll start with you, sir.
Thank you very much, Dr. Eerskin. Duncan Rosario from Oakville, Trafalgar. How do you address the issue of deficit of trust? Because you're asking the entire population, give me your metadata, give me your genome, give me your entire social profile, and I'll use customer resource management, I'll use our entire database, we will take care of you, trust us, when we know that this information has been misused by organizations in the past. How do you convince patients that you will act in their best interests at all times?
So a couple of things. I think that if you look at patients in general, the trust bond with their clinician is probably the strongest compared to other players within the system. That clinician, not just provider, but clinician-patient relationship is pretty strong. If you look at health plans, it's different. If you look at tech companies, it's different. If you look at data brokers, it's very different. So I think we have the advantage of having at least that trust already established. I think that transparency in how we use that information, and that's why I was talking about these creepy meetings. They're literally called creepy meetings, of like when you do trade-offs around, we don't want to trade off trust. So we'll decide not to use data that would actually help a series of patients in a population because trust is first. I think, there's another program that was an interesting program, talk about trust. This was also at Geisinger. We did refund program. And, the refund program is, you put your trust in us, we'll put our trust in you. If you have anything you don't like about the healthcare experience that you had, we're going to give back the portion of the healthcare bill that you're responsible for. So if you have a $2,000 deductible, you can ask for $2,000 back even if your cup of coffee was cold when you were in the hospital. That engenders a lot of trust, and that has been now live at Geisinger for several different years. And so establishing that initial bond that we already have, making sure we make good trade-off decisions about how we use that data, understand and explain to the patient when we use it, that it's for their own good, and use a consent opt-in mechanism versus an opt-out mechanism are different ways that we can make sure we keep the trust.
Gentleman with the mic.
Hello, Dr. Eerskin. I'm an MD student here at U of T and director of the AI and Medicine Student Society. One of the major issues we think about is kind of like the title of this conference, the ongoing change that's going to come in healthcare careers, but it's often framed in terms of what's going to be lost. So I'm wondering where you see opportunities for up-and-coming students and how the training pathways might need to shift to reflect this movement into a digital health world.
Yeah, so, I think it's useful to become familiar. One of the things that you wonder about is when a medical student learns about a condition, do they still open up a textbook? Not so much. Now the textbooks have gone online. But do they learn medicine by opening up a student-based electronic health record system? Where if you're trying to learn about heart failure, you're given, go chase up this student and this patient in this fictitious medical record system and go find the echo and go find the clinician cardiology note and go find the ejection fraction. Go find what the medications are. Learn about that patient in the way that you're going to be practicing that patient, as opposed to, kind of a series of, and I'm sure things have gotten better since I went to medical school, but a series of different, lectures on things. So there's an opportunity to be able to teach differently in terms of how we present information to students. There's an opportunity for students to become familiar with some of the gotchas and the caveats of using these digital technologies to use them safely. So the curriculum can benefit from, this is how you respond appropriately to a decision support alert. This is how you provide feedback in a way that's useful to keep making the system process improvement. And I think that there will be, not everyone, but there will be some medical students that become very attracted to this field, and is a strong need for people who are able to interpret the potential value of technology and how it gets applied on the front lines with all the various different change management components associated with it. So I think there are a number of different steps that we can take to better prepare students, to better attract students to be able to be participatory in terms of how AI and digital technologies are being used as we go forward.
Hi, my name is James Hull. I'm a pharmacist here in Toronto. I'm wondering, the locked-in effect with EMRs and these systems is just so high. The cost to transition is just so much. Are we ever going to get around that to allow competitors to improve user design, to improve layout, to add new features, and really kind of set this industry on fire? Do you think we'll ever reach that point?
So I like the fact that you set it on fire, because that's part of the answer. Of the answers, there's something called fast healthcare interoperability resources, or FHIR. So I think let's go 10 years into the future, okay? 10 years into the future, the big monolithic systems that currently exist with this lock-in syndrome that exists likely will be disrupted by a set of apps that take that functionality and democratize it across the systems. Apple didn't become a $1 trillion company because it locked down its app store and only produce things that were created by Apple. I mean, the calendar's okay, but I can think of better calendars that are in the App Store. So I think it became a $1 trillion company because it allowed the vast majority of the collective genius around the planet to write apps to make things that nobody could even imagine. The EHR companies haven't yet come to terms with that and are fighting against that, that ability for apps to be created. But in the U.S. right now, there's something called a Notice of Proposed Rulemaking going through Congress that is making it much more difficult for third-party companies to not be able to be let into the HR vendors. And it's using this interoperability standard called FHIR. It's using the ability for the vendors to be able to understand how their third-party systems behave in the destination EHR system, and allowing for a new ecosystem, a marketplace for these apps to be able to compete with each other and compete with functionality within EHR. So I'm hopeful, even though that we've gone at this for several years and the market wasn't ready for it, that we're actually going to be in a position, several years from now where we're going to have a robust marketplace of apps that are going to be able to help us out.
Time for one last question.
Hi there, my name is Andrew Bond. I'm the medical director at Inner City Health Associates in Toronto. We're very similar to Jim O'Connell's group at Boston Healthcare for the Homeless. We have a decentralized network of 52 clinical locations across the city providing homeless health care. Obviously, that kind of decentralized network needs the kind of digitized supports in order to deliver care really effectively. The other interesting thing along with this, though, is that most of our healthcare providers are also quite activist-oriented, and so the space of green tech within AI and digital healthcare is an important piece for anybody to adopt it. It's going to be important to have that space commented upon. I wonder, given the huge investment at Partners in Boston, if you can comment on where green tech fits in your digital strategy.
Yeah, so, the option is to pick vendors, vendors that are green tech supportive. I can tell you, not at Partners, but the organization at Geisinger, there was a massive investment in green tech across the facility. And actually, that green tech investment had a huge ROI associated with it in terms of the bill we were paying for electricity, and partly made the case by the fact that the carbon footprint that was being outputted by the hospital prior to it was driving patients with emphysema to the hospital with exacerbations of their COPD. So you could actually make a business case that the investment in green tech, when you're worried about a population at large, is actually worthwhile if you're trying to keep the population healthy. So I think Partners has looked at green technology. The other thing it does is it looks at making sure it has anchor programs for local businesses to be able to make sure that local businesses are being utilized, not just sort of the global conglomerates, which doesn't exactly address your question. But in terms of I work in food banks and noticed there's a lot of free technology that exists to be able to support even just people who are just trying to pull two strings together to be able to provide services to the homeless and people who are hungry. And there are technologies that are very inexpensive, even for those kinds of organizations, to be able to tap into what's available in terms of resources at the distribution center, food bank, and so forth. So I think there's probably an opportunity to do more when it comes to green. There are some early plays into it. There's some clinical advantages in going green, as well as some financial advantages.
Great. Thank you, Alistair. And please, everyone join me in thanking Alistair.